It's even better. Oh, yeah. So I'm definitely wrong session because this is not OB/GYN either. But what I wanted to do, because tomorrow you will have the echo session from Dr. Little, but I want to show you when you are interested in the ultrasound physics and basics. So each of the time when you do those ultrasound RPVI, someday you are interested in vascular ultrasound, these are the two books you really need, the Miele, and the other one, the little brown, is called Edelman. Edelman is Living Up Springs here just north of Houston, and the majority of my slides are coming from these books. All the questions for the exams are coming from those books. But anyway, not just me who hates physics, but the first time when we tried physics in Hawaii, that's what was Pearl Harbor. So this is how much we know about ultrasound. So we definitely, when the Japanese fleet came, we thought those are just clouds. But hopefully the medical ultrasound became just a little bit better. What you need to remember is that when you listen to the sound, this is between 20 and 20,000 hertz. And I'm going to have a hearing test for you soon. But if you're familiar with the piano, this is a really cool feeling that you know what's 20. So the 20 is all the way on the left. And if you want to hear ultrasound, you need not just a regular piano, but an extra 3 sets of keys. So suddenly, when you have 3 sets of pianos, you're going to get to the 20 megahertz. This is what we're usually using for vascular ultrasound. So kind of that much physics I still hate, but you know. So this is the game of audionarch.com. This is your hearing test. Come on, guys, why mute it? Yeah, let's just hear it. Let's painful. So this is going through all those kilohertz. Okay, do you hear anything? You're a dolphin if you hear anything. Otherwise, that's the ultrasound. But previously, if you had any part you didn't hear, that's syphilis. So you have a hearing loss. Just make sure that you got that part too. So the whole idea of ultrasound, how the electricity by those crystals kind of converted into those waves. And again, when we listen to those waves, we'll convert them back to some fancy signals. But again, the whole ultrasound idea is really simple if you just say that you're sending your signals and you want to see those smiling face coming back. So when you send those signals and you just see the black and white screen, the B mode, every fifth you will send a color one. That's why your color is just a little bit slower than your black and white. So that's the old-fashioned way that we said that we have one crystal sending a signal and also receiving it. But we also can time that. So sometimes we have a control delay when we go a little bit further away. The pulse wave, when you're using, that's why you use the same crystal to send the signal and receive. The continuous wave, we're barely not using because you really cannot control the depth anymore. You just know you have a signal or not. That's when you have 2 crystals. One is sending, another is receiving. So here's how you're generating the pictures for the old-fashioned way. And we have some new ultrasound technology called ultra-fast BAM. So this is SuperSonics. That's the equipment name. So not Philips, not GE. That's the company, SuperSonics. So they make the calculation really fast. And this is how you can generate. Resolution still need to improve. This is how you will learn more about echo tomorrow. I'm again a radiologist. I cannot tell you too much about echo. I can try, but I will skip it. Rather than talk about, again, the frequency. This is one of your most important things, is really depending on your source and the propagation velocity, which is really depending on your medium. So when you have those 2 numbers, really easy to remember. Period, when, I'm not talking about ladies, but again, the period, you know, when you see those, when you get to the same level, or you can see as a circle. So when you reach again the circle when it's 12 o'clock again. But the whole idea is to really come per second how many of those circles you see. That's how you get your frequency. So another important thing is on those wavelengths and how the speed, those are the numbers you can see. It's really funny how the bone has really high speed air is 300, but the soft tissue, what we want to memorize, about a 1540 meter per second. So 1540 all the time in the stupid questions, I'm telling you. I don't know why they want you to know that number, but just memorize it. 1540 meter per second. So again, when you're sending and receiving, I just want to give you a short, quick calculation because I still hate physics. So here's your speed. And if you want to go to about 4 centimeter depth, it takes about 52 microseconds to come back. So if you translate it back, is about 1 centimeter, somehow like 6 microseconds. I don't know how they came up with that number. But the whole idea is how they really want to learn how the ultrasound images are really generated. You're going to need to understand a little bit about how the signals are coming through those different mediums, how they are reflecting and how they're scattered and how they're observed. So when you have not much difference between these two medium, then you will have a really easy penetration and transmission. If there's a huge difference, this is when you have a lot of reflection. And based on these, this is why you see those different stripes on those black and white screens called B-mode images. And this is where you have your impedance for different tissues. So that's how you can generate a different pictures and different lines on those ultrasound equipment. We're trying to show you how these angle can be different. So when your angle is getting less, when you're penetrating through this medium, this is going to be definitely a higher impedance, and this is going to slow down your speed a little bit. All these reflection and emission, this is what happens when you have a little bit weaker echoes. If you have a stronger echo, then you really have a strong penetration, and those are the things that, again, you will see on the ultrasound machine. You always need to have these barriers built up because on the dry skin you can get through, but also inside your probe, there's already a barrier built up. So before you even stick it on the skin, you already have some barrier built up here, which is able to let the ultrasound get into the tissue. So the other fun is how you work on the ultrasound with the different frequency and how they go through these attenuations. And again, TGC, this is our favorite button that you can really adjust. So the time gain compensation. Time gain compensation, when you got further, you can get a stronger signal back. If you don't play with the TGC, you will get, again, a weaker signal on the depth. Just kind of get familiar with these bottomologies and know which are the buttons on those ultrasound machine means what. And again, when you have a lower frequency, you're able to penetrate just definitely a little bit deeper. When you have higher frequency, it just observe and the attenuation just happens faster. The other important information what you want to know about the resolution is always in the questions, again, the axial and the lateral resolutions. So axial, when you can differentiate 2 points apart, and for that you just need a faster signals here with the lateral resolution, how you just can focus and able to differentiate between 2 spots. So the higher frequency and the shorter wavelengths, that's what's able to guarantees that able to differentiate those axial dots. And this is how you see those just the shorter signals, but faster. So increase your pulse repetition frequency, able to help you to get those pictures differentiated. So for axial resolution, you just want to do those. So just higher frequency will help you for that. For lateral resolution, you just want to focus on your ultrasound for the certain depth. And on the side of the ultrasound machine, there's a focus button that you should play, and that also improves your images too. So that's the difference. We already talked about the C and PW. Again, the CW, gonna need 2 crystals, sending and receiving. The pulse wave Doppler, you have the same. And one on the linear probe you're looking at, there's like 256 tiny those crystal built in, and on one line that they're trying to improve even that. I'm gonna skip this, you will see all that, but talk about my Doppler. When we do the vascular ultrasound, we have this certain calculation. We really want to measure that Doppler shift, which is again the difference between your transmitted and reflected frequency. But again, we have this cosinus. The cosinus is something that if you have a perpendicular measurement to Doppler, it's going to be 0. So the cosinus 90 is 0. This is why your probe always needs to be in a certain angle with your vessel. So here's your 90. You always want to have a certain angle, and this is where sometimes you just don't see the diastolic velocity, but this is where you want to change the angle a little bit when it's in your hand to be able to get just the better waveforms. So again, on the Doppler effect, if you are in a traffic light and someone playing Mozart, you're not going to hear it, but sometimes going to play a really deep, nice bass music, you're definitely going to hear that. That's, again, how the different frequency you're going to listen to every day. And when you change the probe position, this is how you can make a vessel coming towards you, going away from you, and this is why it's very, very important that you know what's the scale meaning. So the scale on the ultrasound corner is red coming towards you, blue is going away, and you can invert that. So be careful with that. So it's not red all the time as artery, blue is a vein, not red all the time coming towards me. So you can invert that. So you need to always use this as a reference when you're seeing any pictures. So again, I did not change the scale here. So you are pointing that way, you have a blue, you're going that way, you have a red. It's the same radial artery. So the whole idea, again, these are beautiful pictures they just made recently for this lecture. So what we did is the common carotid artery from a deep coming towards your surface. This is why you use this angle correction even just for the color signal. And this is going to give you a reference, red coming towards your probe, blue going away. So you see the common carotid artery, but you also see the IJ, blue. Kind of cool thing that you remember, red, blue, how does it shows? Also, the numbers, 25, that also give you that if you're looking for something really low speed, this is the scale you want to go down. So near occlusion, we're really going down. If you have a stenosis, we're really increasing the scale, but we're going to talk about that just at the end. That's our limit. When I'm looking at, after the bulb, the internal carotid artery, and from a surface, now is going deeper. So the head is here. So the head is here, heart is here, so you're coming towards the head. So now I switched the color scale. So blue is coming towards my probe, red is going away, and also my angle is changed. So something is going deeper, I'm using this angle correction for the color Doppler. Cool? Please say that you got it. Okay. So the whole idea is to really want to trick you next. Oh, before I trick you. So low resistance velocities. Low resistance velocity meaning you have flow throughout the diastole as well as in systole. High resistance waveforms, it's all the extremities when you don't need too much flow. This is what we call triphasic flow. So the low resistance flow, brain, renal, after you ate your gastrics, splenic a little bit. But the whole idea is that you can really tell the resistance based on these waveforms. Stenosis, and here's your post-stenotic monophasic waveform. When the moment you lose your systolic upstroke in your waveform, that tells you that between your measurement point and the heart, you have an obstruction. And what we call hemodynamic significant, I hope I can go back. Thank you. So this is what I wanted to trick you. So here's red. This is the vertebral, deep, coming towards the head. Here's a reversed. See how you can see, and whatever is positive is always on the signal above. So blue is negative, so that's going to be in a spectrum on the bottom. Cool? But they can invert this one too. So you just need to be aware that whatever is going away, that's going to be your negative value. Cool? I have 3 more minutes. What? Oh my God. No, I'm really not going to teach you anything purposely because you're a cardiologist. What I would like to show you, this is the irregular heartbeat, how we're picking up. What I wanted to teach you, which is a very cool, that the artery and the veins, when you paired, you can really nicely say that this is the artery, this is the vein. So if you see 2 blue, that automatically something goes the wrong direction. So it always needs to be red, blue, red, blue. That's going to be kind of easy to see, artery and vein. And this is when these color box kind of helps you. Stenosis. Stenosis, basically your velocity off the roof. These are the aliasing I will show you. But this is, again, the unorganized waveform. So all these different velocity, they just kind of hard to organize that waveform. It's like... the whole idea is to really teach you what's humanly significant. 70%, everybody telling you, but it's really coming from the Spencer-Reid curve. Spencer-Reid played in the 70s with just water tank. So velocity from zero stenosis to total occlusion. Slowly velocity is increasing in your tubing. When you have 50%, there's not much difference. But suddenly when you reach the 70% blocked diameter, you have a flow volume suddenly dropping. So when you cannot carry the same volume through the artery, any artery, coronary, blah, 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 suddenly your flow volume dropping, that's what's hemodynamically significant. Puzzle, if you have a velocity of 300, you can be on this side of the Spencer curve, or you could be on that side of the Spencer curve. The difference is how much your velocity increasing and how much velocity is dropping determines you are in near occlusion or you are in the 70%. So this is another new invention in ultrasound. It's called SuperSonics. So you capture a screen, and then you can put your cursor anywhere you want it. And you can put multiple cursors in the flow, so you can have multiple waveforms. Is that cool? I think it's cool. Another part is, I just can't go to the next slide. So again, you were able to sample the artery and a vein together, not just on a color box, but also on the spectrum. The next thing what we did is, the aliasing. So the aliasing, bring the zero down, increase your PRF. This is how you will get rid of this aliasing. And Nyquist limit is just your half of the PRF, but color aliasing is also present, not just on the waveform. The power Doppler is not depending on your velocity. Power Doppler is very good if you're looking for near occlusions. And finally, some new things in ultrasound. So shear waves, this is how the normal ultrasound waves propagates laterally in nice slow motion. And when you see something in the thyroid, in the breast, and this is how you see nodules in the liver, we started to use that for atherosclerosis. And what we did, come on, man. So this is a cyst. This is so freaking fresh that this was like 2 days ago. I have some dates somewhere. So here's a cyst, extremely dark, really soft tissue. You have an acute clot, and suddenly has a little bit more going up in a kilopascal. So this is the elastography of the tissue in a clot. And my favorite is in the carotid. Elastography in the same thing what we try to differentiate. This is the hard wall of the atherosclerotic plaque. We just started to talk how we use it every day. This is the suture line. See the suture line? This is endothelial hyperplasia. The wall is fine here. This is how you tell where the wall is thickened right there. Cool? So, ALARA, Lewis reasonable achievable. Remember the speed. I swear it's going to be every questions. Remember those. And finally, I want to teach you how to do a proper PFO test. Sitting position. So whoever doing PFO, laying down on a T on the left side. Come on, guys. You're looking for right to left shunt. Physics. If you're looking for right to left shunt and you're laying down on the left side, duh, you need to lay down on the right side because, again, the bubbles that come to the surface to the left side from right to left. But more interesting that, have you tried constipation in the laying down position? No, you're always doing it in sitting. So that's the other reason why we like to do it in the TCD bubble test for PFO. And this is with permission with my favorite patient. So the cameraman was the husband. So the TCD screen is on the head, and we are getting ready to start an IV. This turn comes. First, I'm just looking. Keep your elbow straight all the time and make a fist for me. Just keep elbows for me. So this is a very small mosquito bite, just a butterfly. Little step. Only a small plastic tube stays in there, relax. So this is just a flush. Okay, and as we discussed, shortly after injection, I want you to take a deep breath in. Okay, I will tell you the time. Okay, now zoom out, please. Good. Lift up your arm, pump your fist. Pump your fist. Pump, pump, pump. Zoom this one. You're breathing because you're talking. Okay, deep breath in. Hold it, bear down, push, 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 push. Beautiful, breathe normal. Just breathe normal. If you're dizzy, it's fine. So we put the TCD on the head, we are injecting the bubbles, and it's really fast, it's up in the brain. Thank you.